Great. Thank you for the introduction, and thank you for having us today. Both Rachel and I are really excited to have a chance to talk about the evidence-based medicine curriculum here, sort of where we've come from and where we're hoping to go, and then sort of get your ideas on sort of how to best incorporate evidence-based medicine into the overall medical school curriculum. To start out with, we have no disclosures, and then we won't be talking really about medicines at all today, so nothing really relevant in terms of drug use or FDA. So our objectives for today, so at the conclusion of the session, we're confident participants will be able to describe why EBM education is important for medical students, and sort of the inherent challenges in teaching EBM. We'll be able to report on the longitudinal EBM curriculum in place for Sinai students, including its various components and the teaching modalities we're employing, and then describe strategies for incorporating EBM into clinical teaching, so moving from the preclinical space into the clinical arena. So in terms of our agenda, what we're sort of hoping to go through today, sort of first we want to cover quickly, sort of what is EBM and why it's important. So we know that we're sort of with like-minded colleagues here, but we'll make the very quick case about sort of why this is important and why it's worth teaching about. We'll talk a little bit about how our peer institutions are teaching EBM. We'll sort of talk about the relative sort of paucity of data about how other places are doing this. We'll talk about sort of the challenges of EBM education, and then taking all of it into mind, we'll talk about the Sinai EBM curriculum and what we've learned through implementing it over the last 2 years, really. And then we'll talk about future directions, where we're sort of hoping this is going, where we're hoping to grow the curriculum. So our first sort of task today is to think about what is evidence-based medicine. So EBM has been around for a long time, but in its sort of more modern form dates back to the 90s. And so the idea, the philosophy was it was combining sort of three things, combining clinical expertise and knowledge, patient values and preferences, and the best available evidence to come up with a treatment plan that is sort of grounded in the evidence, but is relevant to sort of the clinical arena and the clinicians on the ground level, and that takes into account patients' values and preferences. So really from its very inception, EBM was concerned about the fusion of evidence and clinical expertise to come up with treatment plans via shared decision-making with patients. So on this next slide, you'll see that evidence-based medicine, this quote, evidence-based medicine is a conscientious and judicious use of current best evidence from clinical care research into the management of individual patients. So basically, like every EBM article you'll ever read anywhere, this is the first sentence. I guess we're just like contractually obliged to include this in our talk today. But really, this is sort of the central tenet of what we think of as EBM. And so see this cycle when we show the slides to the students, and basically every session we do to kind of sort of ground this down to them. There's sort of four sort of central tasks of EBM. So the EBM cycle arises when an information need arises. From literature of clinicians in the ED and in the clinic, we know that sort of information needs arise 8 to 10 times per sort of clinical session. So a very common occurrence in the clinical area. So the first task is to ask a question, so constructing a searchable and answerable question. So we sort of stress to students that sort of formulating the question in a way that's answerable is sort of the key first step. If you just sort of go in blindly and have a vague question, it may be hard to find the right information. So the next step is acquire that information, so searching for best current evidence in the medical literature, so knowing where to search, how to use the functionality, and really Rachel is the sort of key person here in terms of teaching them how to ask and acquire. The next step, once you have that paper, you have that article you think is relevant to the question at hand, your task is to appraise. So going through the study, recognizing sort of issues of internal validity, things like randomization, blinding, allocation, concealment, ability to interpret results. Are they clinically significant? Are they statistically significant? And then once you've done that, the last task is to apply. So apply that evidence to patient care. So this article, even if it's valid, does it apply to my patients? And can I use this while taking into account my patients' individual characteristics and sort of preferences about their care? So that's sort of a cycle that we want to walk students through. And through discussion of the ways that we teach EBM, we'll talk about how that would look. So our sort of next task is to think about sort of why EBM is important. And we'll sort of cycle through this quickly, but we'll talk about what we discuss with students about why we think this is really valuable. So the first step is sort of why EBM is important to clinicians. Like, why does this matter to practicing physicians? So one of the sort of the biggest challenges is would like to think that sort of as time goes on, we're all getting better. For those of us here who are clinicians, that we're getting better, we're getting smarter, we're giving better patient care. But unfortunately, most of the data suggests the opposite, that the longer we're in practice, the less we know and the less good we are at caring for patients. So certainly a disconcerting thought. So this is a study from the Annals of Internal Medicine from several years ago, a systematic review looking at studies that looked for the correlation between time in practice and both knowledge and patient outcomes. So this first table is looking at patient outcomes. So a bunch of studies, emergency medicine, general medicine, surgery, looking at the relationship between time in practice and medical knowledge on testing. And you'll see in this right-hand column, so all of these, a sample of I guess 7 studies, a consistently negative correlation. So the longer you've been in practice, the less well you do on this test. So again, you might make the argument that, well, maybe we just test worse, but, we have that clinical instinct, we have the communication skills that compensate for that, which may be true to a small degree. So on the next slide, table 4, looked at patient outcomes. So things like heart attack, asthma exacerbations, surgeries, bypass surgeries for surgeons. And they found a mix of results, but best case, it seems like there's no effect. There's no correlation between time and practice and patient outcomes. And then multiple studies found negative correlations again, that we seem like we're getting worse as time goes on. So just longer time in practice is sort of not a good way to improve as a physician. We need something more. You all might have seen a study in the last year from sort of the lay press, or a study that went into the lay press, looking at patients' outcomes on the cardiology service. So patients admitted for heart failure or heart attacks who were admitted to cardiology teaching hospitals during the dates of national cardiology conferences when all the most senior physicians were away. They actually found that during these conferences, when all the most esteemed faculty were gone and only the junior faculty were left behind, that patients actually had better outcomes. They were less likely to die from either heart failure or heart attack. So again, data suggesting that just over time, we naturally sort of get worse, not get better, unless we have a conscious strategy to continue to improve. And that's part of what EBM is about. Part of it's CME, continuing medical education. So sort of the next thing is thinking about, like, how do we do this? How do we do EBM? And I feel like I remember as a student thinking that, well, I'll just read a lot. I'll just keep up with all the literature, and that's how I'll stay on target. So if you go to clinicaltrials.gov, where they sort of register all studies, you can see that right now there are 30,000 studies actively recruiting patients. So just sort of committing yourself to read more and learn more is not really a very good strategy unless you have time to read about 30,000 studies over the next 1 to 2 years. So not likely, so we need a strategy. And I think EBM gives us that strategy. So this is something called a cumulative meta-analysis, which I find really interesting as a sort of side note, but I'll keep it brief for the purposes of this. So instead of sort of just putting studies in all at once in a meta-analysis, it puts them in chronologic order. So you see as time goes on where the evidence goes. So this is sort of older. It's looking at patients with acute heart attacks using TPA, so thrombolysis, breaking up the clot. So it's been supplanted by interventional therapies. But at the time, in the 70s, 80s, 90s, this is what we should have been doing. So you'll see... Oh, nice. All right. Thank you for the historical addition. I like it. So you can see the little dot is the point estimate, sort of where the truth lies, and the black line is the confidence interval. So as we have very few studies, the confidence interval is huge. And anything to the left of this line means that we should do it. So you'll see that the point estimate moved left of the line, meaning we should do it as early as 1970. It became statistically significant in 1974. So we had a long length of experience with this. If you look on the right, it's comparing textbook and review recommendations for these therapies. So it wasn't until 1980 that anyone recommended this. So 6 years after it was definitively proven to be beneficial. And it took about a decade more after that for most
groups to recommend it. And they also enrolled about 45,000 additional patients in studies after it was proven to be beneficial. So guidelines can be extraordinarily slow. So we need the ability to do this ourselves. As the counterpoint, medicine is not always conservative. Like for a long time, we love this idea of giving lidocaine, an antiarrhythmic, after heart attacks. So it makes sense. After people have a heart attack, one of the most common reasons to die is having an arrhythmia, an unusual heart rhythm causing death. So giving a medicine makes sense. We just couldn't quit this idea, so just kept doing study after study after study. And you'll see kind of the counterpoint. Even with a preponderance of negative data, we kept recommending it well after it should have been discontinued. So clearly, again, I think we're all on the same page. We need some strategy to think about how we're going to incorporate this. And I think this makes it clear we need to stress to students from the moment they arrive that sort of maintenance of skills is key. However, like I said, not many students are sitting in their second-year classes planning on being obsolete in medicine. So like that may not create a sense of urgency for them. They may not buy that they are going to be like every other clinician before them and have some atrophy of skills. So in terms of sort of the motivation for students, what we have found in teaching this, it is a little different, and I think sort of gives you hints about how you might apply this. So what we've sort of found is sort of their thoughts is clinical excellence and reasoning on the ward. So for these students, they want to do well on the ward. So what we hammer home is this is how you do diagnostic and therapeutic reasoning. It's not so much about maintenance of skills, it's about development of skills. It's about translating research into clinical skill. So for all the non-future researchers, all those hours of research and biostats and epi they sat through, like this is when it comes into clinical practice. So translating research into clinical skills. This is how we really engage in shared decision making. So if I have a patient who I want to take a statin and he or she doesn't want to take the statin, if I have no conception of the evidence behind the therapy, it's going to be a pretty like boring discussion. I'll say take it, they'll say no, we'll argue, maybe I'll win, maybe they'll win, but nothing. But if you have actual evidence behind you can have real decision or shared decision making, which Rachel will talk a lot more about how we teach students to do that. Exams, so like step one. So when we do In Focus 4, which we'll talk a lot about, so step one is like at the top of their list. So emphasizing these come up again and again. So for like our board certifications for EBIM, it's everywhere on there. And sort of the last piece is sort of leadership in medicine. So this is sort of the motivations for the students. I think we already talked about the motivation for clinicians. And the question is sort of less, like what's our motivation as educators? So I think it's all of those things. And then one more piece that Rachel's going to tell you about.
Not expecting everybody to read this slide, but suffice it to say that all of the big accrediting bodies, AAMC, LCME, ACGME, everybody has a requirement that you should be graduating students and graduating residents with these skills. I think that really is all we need to say about this slide.
Okay, perfect. And this huge regulatory sort of like framework makes it a little challenging to figure out what programs are doing. So everyone's trying to like, everything they have, they're trying to like retrofit it for like these competencies. So even stuff like having up-to-date and available on a computer somewhere, like that's part of your EBM curriculum. So sometimes it's hard to figure out what is actually like a conscious decision to teach and what is just sort of being called EBM to sort of check some boxes. So the question is, how do our peer institutions teach EBM? What are other places doing? And so it seems like every 6 months someone publishes a like systematic review on EBM teaching in medical education, basically highlighting the same like 20 studies. No one's done one in the last like 10 years. And then the conclusion is like, do more studies. So I guess you want to get published, like that first sentence already mentioned, the last sentence is do more studies, and then just copy the same 20. So I'll only highlight a few rather than talking about them all. So these are some of the general interventions that they mention. And we'll sort of already point out some issues here. So for first year students thinking about basics, study design, evidence, clinical questions. For second years moving on to application to cases, diagnostic and therapeutic plans. For third and fourth years, applying it to patient care. For fourth years, thinking about shared decision making. This is what most places seem to be doing, but there's sort of a real challenge. So for me, like how capable is a first year student of formulating a real clinical question? I would suspect not very. They probably haven't seen enough patients to really think of real clinical questions. How ready are they as second years to apply them to cases? How ready are they to create diagnostic and therapeutic plans? Should we be thinking about shared decision making before they enter the wards for an entire year? So a lot of this has to do with sort of sequencing and timing, which can be a real challenge. And when we think about sort of who's doing the teaching from these reviews, it's almost always clinicians. So the bars are first, second, third, and fourth year. So almost always clinicians, some involvement of basic scientists. And then a real lack of interprofessional collaboration. So really only utilizing librarians in the first year, which I'm not sure exactly what they're doing for first-year students. Any thoughts?
Probably they are, again, in terms of checking boxes, it could be a PubMed training, which we have in first year, but we don't even really count that as part of our EBM curriculum. That's sort of like pre-EBM curriculum for us.
Yeah, so again, not really incorporating librarians into the clinical work we do for a lot of places. And then in terms of where they're happening, for the most part, they're sort of interspersing with lectures and small groups. So trying to incorporate EBM into sort of small group and lectures that already exist, and unclear when the sort of core basic principles are being taught. I think these two numbers, I think for me, sort of highlight this issue, and then we'll sort of move on thinking about the sort of big picture, what places do. So they had a really good response rate, so 77% of med schools replied. At the end, they had a question which they were really hoping to get some data on, which was, tell us about your innovations to teach EBM to your students. So they only got 10 responses, so like 70% of the people who responded, 80% left the whole question blank, they had nothing to say. And the 10 actual responses were nice, but not really innovative. So there's just not much out there in terms of innovation that people are publishing. Again, yet another systematic review thinking about this from Academic Medicine in 2013. They looked at those 20 interventions I mentioned. And very few of them had elements that crossed preclinical and clinical, and almost all of them were sort of very concentrated blocks. So they'll build sort of like a silo of EBM, so they'll have a week in fourth year, which may be spectacular, but it ends up being just that thing we did for a week in fourth year and not really integrated into the way they think about clinical medicine. So looking at the published literature, diving a little deeper, we sort of chose 3 examples, and then sort of Rachel will sort of talk about one more and an issue we face. So one's sort of Mayo Clinic, probably the best that we found out there when we started thinking about some of the issues of designing our curriculum. So it crosses preclinical to clinical. They have significant instructional time in the second year, both lecture and small group. They have EBM assignments incorporated into all of their clinical clerkships. They have electronic submission of clinical questions, so incorporating sort of ask and acquire and not just focusing purely on appraisal. And they had feedback on those, and they had clerkship-specific journal clubs. What is more typical, unfortunately, is stuff like Vanderbilt, again, looking at their curriculum online, it looks very strong, but again, very brief workshops on things like asking questions and pre-appraised resources, and then some critical appraisal through unstructured journal clubs. Or something like University of Cincinnati, where they have basically like a week of EBM at the end of the year. So it's like the last box they check before students graduate.
Yeah, and as we were talking about what we kind of found, I was wondering, what's going on with Duke? I know Albany Medical College does a lot, and it was sometimes, we have anecdotal evidence about what's going on, and we probably are guilty of this too because we haven't published anything about our curriculum, but that's in the next steps. But it's sometimes hard to know what all is going on out there, and there's not a lot of great insight.
So one last thing about what exists out there, for those of you whose sort of teaching work or clinical work deals more at sort of the GME level, not surprisingly, given a lack of consistent education at the UME level, our residents are not really prepared to do this. So one study out of the emergency medicine literature looking at 17 residency programs, so 400 residents. They took this Fresno test at EBM. One of the main issues in getting evidence about EBM teaching is our sort of evaluation tools are very unwieldy. So this test is like 50 minutes long. It's really like hard to take and hard to get people to take it. The other issue is there's no like benchmark. So like if you're a practicing clinician, like what should your score be? That's really unclear. So I put the numbers there. So they only got about 47% of possible points, doing particularly poorly in some really clinically relevant areas. So that's a little out of context. I will say that this compares or is comparable to the pre-test looking at like preclinical medical students. So basically these residents did about the same as preclinical medical students did at Mayo. So it seems like if they learned anything in medical school, it's all gone. And this seems to be consistent across different studies looking at resident groups.
Yeah, and it's somewhat consistent again with kind of anecdotal. A lot of times in the library we'll be asked to present to residents or interns, and the biggest complaint that the residency directors tell us is they don't know how to find anything. They don't know where to search, and they don't know how to find. So it's a problem.
Absolutely. So I think that will sort of segue to sort of the challenges, and then we'll tell you about what we do here and sort of where we're going with our teaching about EBM. So I think there has been a fundamental challenge in EBM about how we design curricula that work. So this is a wonderful book. I use it all the time, Evidence-Based Medicine, How to Practice and Teach It. I put it up here, one, as a reference if people want to learn a little more, and then two, as an example of sort of where we've gone astray. So the book is something like 300 pages long. So it's 280 pages about how to practice EBM, 20 pages on how to teach it, and then nothing really about curricula. So we've gotten really, really good at practicing EBM as sort of like solo individual practitioners. We're getting better about thinking about teaching methods that work, but we've really put no thought or energy into thinking about what curricular structures work. There is no published literature comparing any teaching method against any other. It's just all pre-post with whatever we sort of come up with. So that sort of comes to the challenges and like why is no one doing this better?
I think something that's, I think probably none of these are unique to our institution. In terms of curricular congestion, a term I learned from Dean Karani, it's just really, really hard. Students aren't just expected to learn basic science and then the basics of clinical. It's patient safety, it's quality improvement, it's systems-based medicine, it's evidence-based medicine, it's all of these things. We're perhaps more lucky than other institutions in terms of having a lot of support for fitting this in the curriculum. But even then, you'll see some of the sessions that we have is April of second year when students have their mind on something else, or spring of fourth year when students are really more thinking about the match than anything else. So finding that time to put it in, very little, and this is largely what Dr. Coyle has been discussing, very little in evidence to support, to say, oh, this works, we should adopt this, or this has been shown not to work, so let's avoid this. The difficulty of teaching the evidence-based medicine cycle in order. So very early on, students just simply aren't ready to generate clinical questions. They don't understand the value or the purpose of being asked to do so. They think of it as a thought exercise as rather than a practical thing. Difficult, I would say perhaps impossible, to fit the entire cycle of EBM within a 60 or a 90-minute session. And so it ends up by its very nature being a little bit disjointed, where they'll get some appraise here and some acquire here and some apply there. But it is really hard to come up with a comprehensive EBM exercise. And then, as we've alluded to, the lack of kind of interprofessional support and interprofessional teaching that's encountered.
And then in terms of sort of teaching, whether it's sort of clinical or classroom-based, we have a number of challenges there as well. So trainee unwillingness to admit uncertainty. So like the very first step is asking a question. So if trainees are not comfortable asking those questions, you'll never get anywhere. In a lot of places, we have a hidden curriculum that sort of cuts against this. So like, why look it up when I can just up-to-date it? Like, why look it up when my preceptor has clinical expertise and he just said to do this or she just said to do that? So we're sort of lacking faculty modeling. There's a real lack of faculty development around this. So again, in some of those sort of systematic reviews, they found that maybe only 5 programs in the country claim to have any faculty development program for evidence-based medicine teaching in the clinical sphere. And then sort of this last issue of faculty ability to sort of deal with this. So the cycle can be very long. So do we have the bandwidth as instructors really to sort of to do this? Do we have the time? Do we have the space? And then ask a clinical teacher, can I really be myself, appraising 3 articles a day if I'm assigning the students to do it? So we have a number of sort of different challenges that sort of face us when we're thinking about EBM. So given that, we'll sort of talk about what we've done here. So Rachel and I will talk about sort of the pieces of the curriculum that we teach, though a lot of it we teach together. We'll also highlight a few things that are not part of the things we teach that fit into the curriculum. So I will say this once and say it probably each time, but for those elements, I will talk about how they reflect on what we do. They obviously have their own goals and objectives that they meet otherwise, so I can't speak to that. So this is sort of the overview of what they have. So as we've mentioned, our goal is to build a longitudinal curriculum that is integrated into everything else they do, to sort of make it relevant and experience-oriented. So we'll sort of talk through all of these sessions together and then talk about what we've learned through teaching them, what our takeaways can be as clinical or other teachers. So sort of their very first exposure to EBM is through the Scholar program as part of InFocus. So InFocus, for those who don't know, sort of blocked out weeks each semester through all 4 years of the curriculum. They tackle things like biomedical research, evidence-based medicine, advocacy, teaching skills, leadership. So all 4 years of the curriculum. So InFocus 1 through 3 is very heavily focused on biomedical research through the Scholar program. Again, little asterisk to remind myself that I do not teach any of this, but this is sort of the foundation, nor am I probably equipped to teach some of this. This is sort of the very foundation of what they know. So this is sort of research and thinking about being a producer of research. So students leave this feeling very confident for their summer research project and feeling like they could be researchers, they could be creators of research. So obviously there are probably lessons for clinical teaching, but I don't know what they are because I don't teach it. Great. So that's sort of Scholar, that's the sort of foundation, that's where they come in when they first encounter Rachel and I. So in the second year, in the fall semester, they have InFocus 3, so it's the last piece of Scholar, and this is sort of the first exposure to evidence-based medicine. So we try to hit all 4 steps in the cycle, ask, acquire, appraise, apply, through sort of one lecture. And again, our goal is to transition from Scholar, which is biomedical research, thinking about being a producer of research, to EBM, which is being a consumer of research. How do we sort of handle research that's already done that we're now interpreting? And so our strategy in teaching this session is they're novices. They have basically no exposure to EBM. So we try through the course of an hour basically to do one long worked example. They don't have much experience. They don't really have an ability to sort of problem solve in this realm. So we work through sort of one long example with them to sort of show what EBM and what it can do. Things that we've thought a lot about in terms of the clinical teaching that relate to the way we should teach EBM. So tie into their educational experiences, so make it relevant for them. So I'm sure the students are annoyed by it, but constantly harking back to what they learned in Scholar and how that relates to what they're doing now. Again, the need to establish a sense of urgency, so tapping into their existing motivations. They may not be as on board with EBM as you think. Again, not many people are already planning for their skills to deteriorate, so you want to make it clear why, even if it's not the same why that you have. And then the last bit is sort of enthusiasm for EBM matters. True for all teaching, I feel like especially for EBM. So I want to be especially enthusiastic and sort of show what EBM can do and what it can be used for.
So the first chance that students get to roll up their sleeves, so to speak, and really participate is during the second semester of their fall year in the Art and Science of Medicine course. Again, not run by us, and this actually predates us, but it fits in really nicely. And a lesson for clinical teaching that's not listed here, but I will jump to it. You need to name it. You need to say, like, this is evident. Now we're doing evidence-based medicine. And the slide, the evidence-based medicine cycle slide, has now been incorporated into this. The course directors were, more than happy if you provide them a slide to just go ahead and put it in and say, this is what we're going to be doing today. So putting a name to things, that comes up all the time at the clerkship meeting of, we give students feedback, but they say that they didn't get feedback because we didn't say, this is now you're getting feedback. Same thing with EBM. You need to say, now we're going to be talking about incorporating EBM into your practice. So the steps that we're focusing on at this point are appraise and apply. The students are first treated to a wonderful wonderful lecture by Dr. Su, who is the chairman of our Geriatrics and Palliative Care Department. He's also the chairman of the United States Preventative Services Task Force, about how the PSTF establishes and grades its practice recommendations, so the evidentiary basis of the practice recommendations from a national organization. Students are then provided with a clinical vignette and an article. Again, absolutely no probably ability or instruction at this point on how to find an article, so that article, just deus ex machina, is provided to them. They then go through a critical appraisal study of the study and a determination in a group of whether the study is applicable to the patient in the vignette they've been provided, and deciding, okay, based on this evidence, is the evidence applicable to the patient? And if so, should we recommend that this patient, in this case, be screened for lung cancer, because that's the topic. Some lessons for clinical teaching. Even routine care can offer opportunities to review evidence. I might even say especially routine care. If anyone is familiar with the Choosing Wisely recommendations, almost all of those are about routine care, diminishing overuse of tests in routine care. So it doesn't need to be, a rare traumatic event or intervention. It really can be your everyday practice. Also highlighting the connection between practice guidelines and recommendations. A lot of times students will just be told, is there a guideline? What does the guideline say? Don't just ask them, is there a guideline? Ask them, okay, in the guideline, is there levels of evidence? Is there an introduction to the levels of evidence? What does the guideline say? But also, how strong is the level of evidence supporting that guideline? These guidelines, these practice recommendations, they are, or they certainly should be, evidence-based, and that is EBM on just a larger scale. So again, making that connection, saying, this is evidence-based medicine, or this guideline should be evidence-based. Don't just take the recommendation from the guideline, but look at the evidentiary basis of the guideline.
So sort of rounding out their EBM education and sort of the sort of second year is in focus for the second year and their spring semester. So really focusing on their abilities to appraise and apply. So it's 9 total hours of instructional time. So 5 hours of lecture with me, 4 hours of small groups and journal clubs. In terms of sort of the structure, they get, again, those 5 hours on the topics that you see there. And then they have journal clubs sort of on similar or related items. So some of the things that we sort of have learned in thinking about this, and I'll talk more about the structure, is one, that to introduce EBM principles. If you have a very novice learner, we really need to minimize medical complexity to reduce the sort of cognitive load of the sort of the exercise. So I think, talking about the journal clubs, the journal club that worked the least well by far was the most medically complex topic. So the one that focused on sort of this complex intervention with a medicine they weren't all that familiar with, that one worked extraordinarily poorly, because they're grappling with sort of like, what is this? What am I doing? So kind of to Rachel's point, I think it kind of runs counter to our thinking in the clinical sphere. But sometimes like something really simple, like bronchitis or the flu, like something that I could explain to like my mother in 10 seconds. Like that's the kind of stuff where they really have the ability to focus on the evidence-based medicine, because they're not really grappling with the medical complexity piece. For this, again, we really, really wanted to be experience-oriented and as much as possible in a non-clinical setting, sort of patient-centered. So for this, they had just come off their blocks featuring pulmonary, gastroenterology, and MSK. So in 9 hours of instruction, every lecture, every article was either Pulm GI or MSK. So again, making it relevant to their experience. Again, trying to reduce the medical complexity of what we're talking about. Again, we want to tie into their motivation. So they're about to go into the wards, that's late second years. So really focusing on this being skills necessary to succeed on all of their clerkships. And then obviously in April of second year, everyone's kind of just thinking about step 1. So tying in explicitly again and again to sort of knowledge they need to know to do well on step 1 for these preclinical students. The one other aspect we did that worked really well this past year was sort of the 4th journal club, did small group. So each journal club around 15 to 16 students per. So we actually chose 4 different articles for them to read and sort of discuss with the rest of the group. So I actually had polled all of the previous year's classes on the most common questions they got asked by their peers they didn't know the answer to. So the first was, what is this rash? But I couldn't think of how to apply that with EBM, so that was thrown out. But the ones that actually worked were, should healthy people get flu shots? So like, should their friends get flu shots? Should healthy people take multivitamins? Should their parents take aspirin? And should young women get mammograms? Were sort of the 4 questions chosen by students. So in the small group, each set of 4 had to read the article in advance, and they had to sort of summarize the evidence for their peers and then sort of make their case. So for us at least, when we're thinking about teaching EBM, we're always trying to hit at least 2 steps in the cycle. I think the biggest issue with the way EBM is taught is it becomes very like fragmented. There's almost no whole task EBM exercises out there. So we've tried very hard to sort of push them into apply, even in a non-clinical space, because second-year students are can understand flu shots. They've gotten flu shots. Like, everyone knows what a multivitamin is. That works pretty well. The sort of last thing we learned from doing this, and I think I've thought a lot more about in the clinical sphere, is it doesn't always have to be an article with some huge issue. Like, you can practice EBM on pretty good articles. I think sometimes EBM devolves into let's pick out every single flaw or find the worst article and kind of rip it apart. Sometimes it's okay to choose things that are good and then talk more about applicability and sort of generalizability issues. So I think those are some of the lessons we learned from In Focus 4 this past year that we're going to sort of apply to our next time through. But again, our task, our sort of, the sort of key thing we're trying to do is, again, trying to push them through all steps of a cycle as much as we can in every teaching encounter.
So by now, students have had a couple of encounters, some fairly robust experience with appraising and applying. And I get them in April, April of second year, when they're thinking almost entirely about step 1, or any leftover brain power is devoted to anxiety about going on to the wards. So it's a little bit of a difficult time. But that being said, we do try to not do too much, give them the theory that they need, but not too much theory, and also give them some practical steps for the kind of information they're going to need. So this is a 90-minute session with the students. It's an introduction to the PICO clinical question format, why it exists, what its shortcomings are. In case anybody's not familiar with that, the PICO format is your patient or your patient population, your intervention or your exposure, your comparison or your control, and your outcomes. I actually introduced students to the PICOT model, and this I think was pioneered at Duke, where the 2 T's at the end stand for type of question and type of study. So what type of clinical question do you have, and therefore what type of study would be the ideal to help you answer that clinical question. So it's a really nice tie back to In Focus 4, where for the therapy journal club, they're appraising a randomized controlled trial, and for the etiology, they're appraising a cohort study. So it kind of ties that back. We also review the evidence hierarchy, the pyramid. Again, not the first time they've seen it, because they saw it in Focus 4, so that's another reinforcement point. I want to just step back and say, at this point, it's their first introduction, and students are not prepared to generate clinical questions. They have had a little bit of clinical time, but they're not ready yet. And so what we're actually doing is introducing them to the model and then dissecting. So we give them the questions and ask them to pull apart which element of this question is the comparison, which is the outcome. And it is based on, what we did this year is we actually based it on a simulation case that they had that very same morning. So in terms of tying it into their clinical experience or exposure or the curriculum, it helps to have that direct tie-in. Because at this point in their educational careers, a lot of the times they just have background questions like, what is the mortality rate, or what is the differential diagnosis for this condition? We also introduce them a lot to the kind of resources that are good for that. So we want to give them the EBM stuff. We have to give them that foreground PICO questions, but we also recognize that they have a lot of anxiety about just being able to answer general questions. So we give them a framework. We suggest resources and give them a framework for appraising background information resources. Make sure the textbook's not old. Make sure it has references to current primary literature and things along those lines. Lessons for clinical teaching, as I've been mentioning, early on students really do just mostly have these general background questions. I find that even a lot in my teaching with interns when I ask them to generate questions, they're mostly background questions. Generating well-formulated clinical questions is difficult, so students need guidance. They don't like to admit that they're not ready to do it, so feel free to not just tell them, hey, do this, but work with it. Work with it through them. And then again, encouraging uncertainty to allow students to feel comfortable admitting that they don't know and that they need to go ahead and find out. This is just one of the slides from that presentation. I realized after the first year that we taught this that students still didn't get what the point of the PICO question was, and really trying to explain to them that the way the question is going to spring forth in their minds, is this patient at risk for developing sepsis? Does this patient have a DVT? How do I figure it out or not? You cannot go to PubMed and search Mr. Jones sepsis risk. You have to get from there to, my patient is a member of what population that might be recruited reasonably for a clinical study. So we're really trying to make that really, really explicit for them so they understand the value of what they're being asked to do. And it's not just a thought exercise. In Focus 5, this is right at the very beginning. It's part of what used to be called Clinical Skills Week. Now it's part of In Focus 5. And they want to get their hands wet. The sessions that are always rated best during In Focus 5 are like venipuncture, So they don't want lecture. They really want to be doing. And so I basically just throw a worksheet at them. I'm like, go ahead, find the answers to these questions using these functionalities in PubMed. It really is meant to be practical. The great thing about PubMed is it's trying to be as Google-like as possible. But if you know a couple of things, filters, sorting, clinical queries, you can be a much more effective PubMed user. And that's what the worksheet is about. So first, I throw the students into it, ask them to do it, find it, kind of grope their way through themselves. And then we do walk through. And then tying PubMed searching back to EBM. How is PubMed searching EBM? If you run a search using an abbreviation, you're not going to find all the evidence. So that really diminishes the chance you're going to find the best available evidence if you don't start with a search that yields all the evidence. In terms of lessons for clinical teaching, a lot of times trainees are asked to go and find a study, but don't just ask students go and find the study. Emphasize not just the results, but also the process. Tell them, I want you to find a study using PubMed. It will both strengthen these skills that we're trying to teach them. It will diminish over-reliance on shortcuts, things like UpToDate, which is great, absolutely fantastic, but not the only thing they need to know how to use. And again, emphasizing the process, not just the results. Oh, okay, you found that study. What search functionality? Did you use any filters? Did you use the clinical queries tool? Knowing that students that you care about how they actually found things will, and maybe it could even be featured into their grade in some way, will help students care more about it.
So as you see, as we're moving into sort of the clinical space, we've sort of moved completely away. We have no lecture-based teaching or sort of more transmission-based teaching during their clinical sphere. It's all small group, very problem-centered, very hands-on. So in Focus 6, 3 months after they've started rotations, we have them back again to talk about pre-appraised resources, so things like Cochrane Reviews, ACP Journal Club, where people have taken primary literature and already appraised it for you, so you get both the primary literature, their appraisal, and a summary, so all together, rather than just sort of a review like UpToDate is. So for this, we have them for an hour. We've chosen to break them into small groups. So Rachel and I do 12 sessions over the course of the week to keep the numbers quite small. Again, a lot of what we think is valuable is making it experience-oriented, related to what they've just done. So we have 4 different cases. So one for the students coming off neuropsych, it's like antipsychotics and dementia. One for the people coming off their pediatrics rotation, so reflux in infants. One for the medicine cohort, which is DBT diagnosis. And then one is for the surgery anesthesia crew, who gets one on fluids in shock. So again, we've chosen things that they 100% saw. Like you can't go through anesthesia or surgery and not see shock. Like you're going to see that. So the point wasn't so much that they didn't know the answer to the question. The point was if once they have this sort of medicine down, like how can they use these resources? So again, trying to reduce medical complexity to focus on the evidence-based medicine piece of it. And again, it's a good example with everyone who has any trepidation. So I am now, through this, teaching a session on pediatrics and evidence-based medicine. I know nothing about pediatrics, like zero, and we somehow make it through without looking totally stupid. So you don't have to know a ton about the subject area to sort of teach about the EBM concepts there. So again, we tie into student motivation, so doing well in the wards, helping them choose the right article to present on rounds, helping take appropriate shortcuts, and looking for pre-appraised resources when necessary. One thing that we got in all 12 sessions, both times we've done this, is students still tend to confuse peer review with like critical appraisal, that like, oh, it was published in like NEJM, like why do I need to critically appraise it? So we're sort of always hammering home that studies have flaws, published studies have flaws, and even if they're perfect methodologically, you may have applicability issues. So sort of constantly reinforcing that though appraisal may not be something you do every day due to time constraints, it's still a skill you need to be able to turn on when you need to.
So this is also another thing that existed before that we're really fortunate and happy that it exists. And we just asked for our EBM cycle slide to be inserted so it's really clear how this ties into everything else. This is an exercise in the psychiatry clerkship, and it's really fantastic because it does go through the whole cycle. Students are asked to select a patient, develop a clinical question based on that patient. They are asked to formulate a clinical question using the PICO model, find study to answer the question, critically appraise the study, and determine whether it's applicable to the care of that patient. And then they need to go ahead and present that to an attending during the month of their psychiatry clerkship. So it is required in order for them to pass the clerkship. Lessons for clinical teaching, we would love to see this rolled out to every single clerkship because, again, it allows the whole cycle to run through and it makes it very, very, very immediately obvious how it is applicable to everyday practice and to clinical care. Oh, this is me too. So by now we've run through all the steps. They've appraised, they've applied, they've asked, they've acquired. But all the apply up to this point has really been, is this evidence applicable to this patient? Now is when they get the other side of that coin, that apply coin, which is how do I incorporate my patient's values, my patient's preferences into the practice of medicine, of evidence-based medicine. So we introduce students to the concept of shared decision-making as well as decision aid tools. Students are presented with a case, and this is when they do a role play exercise. So again, trying to move away from that lecture and really get students involved. And then, you know, I was very impressed. We had some really valiant efforts on the behalf of the physician student, or the student who was playing the physician in the role play, to try their hand at communicating the evidence to their patient. You know, it was actually two scenarios, both about should this patient take a statin, and one was a younger, healthier patient who was, you know, more pro taking an intervention, and another was an older, perhaps a sicker patient who was more averse to taking a medication. So really trying to, again, work through that whole piece of the cycle all the way up through the communication piece, which is probably the hardest piece of the entire thing. So in terms of lessons for clinical teaching, students are watching, they're learning from the behavior that they observe. Practice shared decision-making, call it shared decision-making, put a name on it. And, you know, this is, you know, just a huge challenge that we've alluded to before is the hidden curriculum. So when students see you know, paternalism in practice, then they think, why do I have to do this? This takes time. It's hard. It's not easy to have these conversations. So do your best, of course, to be a model. And then, yeah, just tell students, did you see how I just engaged in shared decision-making with this patient? Because otherwise, even if they see it in action, they really might not recognize that's what they're getting. Oh. Okay. Last, we'll go pretty quick here. Introduction to internship. I try to give them a recap to some of the quickest, most effective evidence-seeking strategies. So we're trotting this back out in terms of trying to prepare them for, of course, their intern year and residency. I try to sneak in some core EBM principles just as a review. And here, too, the lessons for clinical teaching is always to emphasize the process, not just the results. So asking students not just what study did you find, but what resources did you use? Did the resource that you used feature any evidence grading, and that sort of thing. So emphasizing that process.
So having sort of done all of this, we want to sort of highlight as a summary all the sort of things we've learned about sort of teaching EBM, and then think about sort of where we want to go and how we want to sort of engage everyone here and everyone sort of within the larger medical community on teaching EBM. So as sort of a clinician, for those who are in the clinical sphere here, we're sort of these traditional models, so we can all role model, we can all weave evidence into clinical practice, and we can target specific skills. So even small things like modeling can be sort of extremely valuable for student trainees. So again, we want to diagnose our learners. So keeping in mind this potential for aptitude treatment interactions, that sort of novice learners, if you give them too much problem solving and you don't give them support, they'll do poorly. If you have too much instructional support for advanced students, they're going to sort of rebel and not do well either. So a lot of what we designed is trying to build very strong instructional supports early on and then slowly taking them away. And sort of by the end, it's all about problem solving. Our role in instruction is very minimal, sort of giving them the space to put these to practice and then taking them to the clinical sphere. The sort of fourth one I think is key. So like, don't feel you need to be a statistician or a researcher. It's about using these. It's not about doing them. So like the math behind a lot of what I teach, I could not explain. I am not a statistician. You don't feel like you need to be one. And there's other things we can do. So model, like ask questions in clinical practice. I've actually found that one of the most useful things that I can do when teaching is to tell students when I have no idea if there's any evidence behind what I'm doing, or if I know there's no evidence, being very explicit about that. So there's not always evidence for all of your decisions, so being clear about that I think has a lot of value. And then again, discussing sort of diagnostic strategies and pre and post-test probabilities has a lot of value for students. Last but not least, so select topics for question framing where you know there's some evidences exist. So like some of my I felt worst when I sent students on wild goose chases. So have some conception of sort of what's out there. Again, you want to make it sort of not so medically complex, make it feel very doable for students. For those who are interested in doing more critical appraisal, we have critical appraisal worksheets we've designed here. Again, being very useful sort of scaffolding, providing support for students. And then for those who have any role in any clinical clerkship anywhere, we'd really, really encourage you to think about incorporating whole task EBM exercises, going through the whole cycle together. I think what we've tried to do is reduce fragmentation, but that's a challenge sort of in the non-clinical space. But in the clinical arena, I think there's a lot of room for growth there. So in terms of what we want next,
we want to begin to put some evaluation to it, pre-test, post-test, to make sure what we're doing is really working, make sure what we're doing is better than what we've found out there, or is graduating physicians who are more ready to be competent EBM practitioners. We're starting right now encouraging everyone in this room. We want to continue to encourage everybody to incorporate these kind of activities into their clinical clerkships. If every clerkship had an activity like the psychiatry activity, that would be wonderful.
We want to try to think about ways to improve and enhance faculty modeling, so increasing the number of EBM mentors we have at the institution. So think about ways to develop programs to have educator development for faculty and for residents on the front line who do an incredible amount of this teaching. So again, find opportunities for these whole task EBM activities. And then the last is create opportunities for students to further explore these in clinical context. So we have a group of fourth year students now who sort of designed and built an EBM elective. They're doing that with Rachel and I now. I've had like multiple students approach about longitudinal journal clubs. So there's a lot of interest there. So I think we're looking for ways to create more opportunities. And so I fear in our exuberance of teaching about or talking about EBM, we've cut into our time for questions. But we do really want to have a space for dialogue. If people have questions, thoughts, we'd love to sort of chat more about that. And that's it. Thank you.